Welcome to a day in the lives of Jim and Rob, or Tales from the Trenches. I'm joined by my partner tonight, Dr. Rob Neuker, the Surgical Director at OCC, and we're going to spend the next 50 minutes or so together with you, bringing cases that begin at the very start of the glaucoma journey and taking you to some cases that end at the very end of the journey, all of which are challenging in their own right and represent some unique views of the glaucoma management space. These are the financial disclosures from my partner. These are my financial disclosures. And we're going to start off with a case here that I think is pretty interesting. So, Rob, I don't know if I've shown this to you or not. This is a 68-year-old Hispanic male. Vertical cup to disc is good. PSD is good. Risk of progression was 30%. Looking at this data, just sort of off the top of your head, anything jump out at you that's particularly concerning as far as monitoring a patient like this versus somebody else with identical data, and then that one little piece that sort of hangs out there like a dangling participle, right?
Yeah, well, I mean, everything's kind of borderline, obviously. I mean, sentinel corneal thickness a little bit thin. The IOP, the actual, and then the corrected IOPs are, higher than we typically want. And then the hysteresis is much lower than we want too. So, I mean,
yes. So when I look at a patient like this, I think to myself, if I'm going to see a conversion, I either want that CCT to be low. I've actually sort of rolled over to the corneal hysteresis as being the more remarkable finding. But I think for all of us, we need to look at this data from the beginning and sort of put risk factor in place. I mean, here's a perfectly normal visual field. Here's the baseline, and here's the follow-up. Your thoughts, Rob? I mean, obviously, over 5 years, this patient had a significant shift, right?
Yeah, I mean, this is why I like, photographs. Technology changes, our machines change. So I always like having photographs, and this is good. The exposure is a little different, but you can see that the cup definitely looks bigger, kind of inferior temporally and superior temporally. I think you see more changes in the blood vessels, especially inferiorly. So
if you had a normal visual field here, Rob, which we do, would you treat this fellow based on that noted progression alone?
I would, and over time, we had less good tools, but this gets into this concept of pre-parametric glaucoma, before visual field changes, and the data shows you can lose 40 or 50% of your nerve fiber layer before it starts to show up. So yes, I think all of us, I mean, you can chime in, but I think we've become more aggressive, and I think for early patients, glaucoma suspect / early glaucoma, the data is that imaging, and now OCT is the standard, is the better way to go.
Yeah, this patient represents one of those typical cases from the trenches, right? You see the patient and then they don't come back for many years. Coming back, they're now very visibly moved into the glaucoma space. I've repositioned my thoughts on individuals like this and like you. I'm much more likely to initiate treatment to prevent onset of disease as opposed to preventing progression of the disease. And I think this patient is really representative of that new paradigm of, if you treat a patient early in this process when they had low hysteresis, moderately elevated pressures, the risk factor was reasonably high for 5 years. I don't know whether you would have completely stemmed the progression that we've seen here, but I certainly think that you might have had a significant opportunity to decrease the rate of progression and increase the longevity of the patient's visual performance. Mm-hmm. And here they are with a classic GCC loss to go along with it. So this is one of those patients that I wish I had it back kind of patients. And I think most of us see a lot of these. I have moved my needle to a very different place. Normal visual fields doesn't bother me at all. I agree with my partner that nerve was suspicious, but not glaucomatous. But I would certainly have wanted to have thought about this patient being treated much earlier in the process. And, unfortunately, we do lose them.
It really is asymptomatic until it gets very bad. And it's tough. We have these conversations, unfortunately every week, that by the time the patient's noticing the vision loss, they're not going to come back. So especially the younger they are, the more I worry. I worry much, much more about 50-year-olds than I do 90-year-olds, just because we have to keep them seeing for a long time. And yeah, I think, with taking everything back, looking at all the information retrospectively, I think this guy has glaucoma. It's just where you draw the line in the sand. And I think we draw the sand really early now. early as possible. And I think the data supports that treatment's more effective and easier. One drop therapy or whatever it is, SLT, will often be all they need.
So this is a different kind of case, and I think I've shared this with you in the past. You might have actually even seen him at some point. I know you gave me some input on this one, and I found him fascinating because of the simple fact that here's a 33-year-old who was referred to the practice to myself by another optometrist for second opinion on what the patient had been told was end-stage glaucoma, right eye only, left eye was normal. He had been given Travitan, travoprost in this case. Baseline IOP before treatment was 18. We got that info from the previous treating doctor. Visual acuity in the right eye was not off tremendously. It was 20/25 in each eye. No family history. IOPs were 8.4. He was currently being treated at 14.7. Visual fields, I'll show you in a minute. Patient had a significant wiper defect inferotemporally in that eye. And he had been referred for an MRI of the head and neck for contrast by the other doctor simply because the doctor felt that this was such an unusual form of early glaucoma. There are the two optic nerves. As you can see, they are wildly asymmetric. Nerve on the right is a massive megapupilla, getting close to about 4.0 millimeters squared. The one on the left is a totally normal nerve at about 2.0 millimeters squared. The one on the right has multiple features that I think are of interest, and I'll have you comment on them too, Rob. But he's got down below, he's got a coloboma type defect, and you can see the nerve fiber layer dropout on the photo alone. It's just got a huge wedge of RNFL dropout inferiorly. Cup to disc is significant, but not remarkable in the sense of advanced end-stage glaucoma. He just has that very large notch or inferior zone of malformed optic nerve. Visual fields, I think they match the presentation. This is a bad picture. I'm sorry about that. I don't know how it got tilted out, but you can see the RNFL shows that large area of loss. Ganglion cell has a perfect wiper defect located inferotemporally. So clearly damage to the nerve with functional damage as well as structural damage. Patient returned about 6 weeks out, said he didn't like the look of his left eye because the right eye because of the fact that the periorbital pigmentation had taken place. And that's when you and I spoke about doing a laser on him. But my question to you, Rob, is if you take a look at him sort of organically, is this glaucoma or is this a hereditary disease that he had his whole life? And at 33, this was his first eye exam.
Yeah, I mean, I guess the answer is both. I mean, I guess glaucoma is hereditary by itself, but and it's remarkable the asymmetry. We certainly see that sometimes, but these large optic nerves, and we see this commonly in African American, where both sides are very asymmetric. So it's weird, but nature is often asymmetric, and it's just weird. He has two different optic nerves. It's the way he developed, obviously. But that said, these large optic nerves probably don't have as much axonal support either. So I think, and I think you can treat him as a glaucoma patient. I wouldn't say it's end stage either, but it's not good. He has a visual field defect, and corresponding nerve fiber layer thinning. So I think this nerve is certainly at risk. So the value, when you look at the OATS study, these at-risk eyes, and this is kind of beyond OATS study, the EMGT, early manifest glaucoma trial would support, lowering his eye pressure. So I would vote, yeah, that this one eye probably does have glaucoma.
So this begs that interesting question that you and I see regularly, and I think we see it in a lot of different dimensions. Patients who have had AIONs with a field loss, patients with MS with a field loss, patients with traumatic optic neuropathy with a field loss or other types of induced disease, but who also have marginal pressures. And it typically is one eye. And the question then becomes, if the disease is well known and the cause is known, do you still treat, this is rhetorical to you, should we still treat that visual field loss and that nerve because they've already lost half of their fibers and they're at risk to lose the others at a different rate than the other eye is without having had no loss? You and I've had this discussion a lot, but I think it'd be a useful context for our listeners to get a perspective on.
Yeah, it's not a slam dunk, but I really do treat all MS patients or patients with optic neuritis from that as minimum glaucoma suspects. I think there's argumentably, if they have kind of very atypical, patterns, and sometimes the nerve just looks a little pale. They don't always have the cupping, but I think I treat them as glaucoma suspects because I think their nerves are, inherently weaker. And I think the same thing goes for the AI1 patients. They often get like this notch, after the fact, after the dust is settled, this inferior notch, if it's, non-ischemic, some vascular event, and there is data support, also like after a vein occlusion, vascular insufficiency is related to eye pressure not always being well controlled. So many of those patients I'll treat, and maybe we'll choose like a neuroprotective agent where there's, eye crush models and more experimental models for those. But I think you could argue that lowering those eye pressures, and especially in the vasculopaths that had a ischemic optic neuropathy, I would seriously consider treating them. And once again, knowing that they're not your run-of-the-mill primary open-angle glaucoma, but I think there is value when you look at, there's some interesting new studies looking at kind of axoplasmic flow at the level of the lamina cribrosa. And I think, minimizing, deformation of the lamina cribrosa is beneficial. So that's the kind of the value of lowering intraocular pressure.
Yeah, I mean, a couple comments in sort of addition to that. In my AION patients, obviously, colleagues, if you haven't had those patients in your practice, one of the things you want to look for very carefully is what's the nerve size. Many of them have hypoplastic nerves, which puts the other nerve at risk as well. And I would recommend treating both eyes, even if the other eyes show no damage, simply to hope to prevent the onset, as Rob said, from a congestion of that lamina cribrosa, because the fiber bundle is too large to fit into the opening and the patient gets compressive disease. So that's one. And number two, this one's a little more esoteric, I think, Rob, and that's the patient with optic nerve drusen and visual field loss. Usually they're both eyes. Sometimes the field loss is markedly different from one eye to another. What are your thoughts about that? Because I've have a bunch of those in the practice that I manage, but curious to have your perspective.
Yeah, optic nerve head drusen is one of these things that the more you look for it, the more there is. The statistics in the Caucasian population in the United States, it's from 1% or maybe up to 5%, depending how you define it. And it does get more common over time, like the drusen kind of migrate to the surface over time. And, so when I was back in Boston, we did a study looking at OCTs of patients with drusen, and then also another one with drusen and glaucoma. So rule number one, drusen patients have a lot of visual field defects that are from the drusen. Number two, they still can get glaucoma too. So you can't just write it off, oh, this guy has drusen, it's from his drusen, because they get glaucoma too. So that's always a trick with this population. So once again, I will err, and especially, looking at, maybe a neuroprotective agent with like brimonidine or something, lowering the intraocular pressure probably does help facilitate axoplasmic flow, because that's the problem. These little chunks of calcium are squishing on the ganglia. So that's the problem in that disease state. That said, I think there's value in a lot of them, and I do treat, especially depending how much visual field loss they have. If it's getting close to the middle, I just don't want to take any chance. And that's a little bit, less proven at soft space, but that's always the warning, as drusen patients do get glaucoma too.
So let's leap back to this person to finish off this discussion, because this is a kind of a large field of patients, and you're probably going to run into 1, 2, 3, maybe all 4 of the 5 of the categories over time. Rob and I certainly have several of them in all the categories that we treat. But this fellow increased his mean deviation over time, not surprising. And this was stable. So I'm looking at a stable OCT, relatively low pressures. We did send him out for laser. He did not have it done, but instead, I think I might have been mentioned earlier, his physician put him on 30 milligrams of atenolol because he was actually finishing his MBA at one of the top schools in the country and was really under a fair amount of stress. And so we were getting good IOP control down in the 11 or 12 range from systemic management, but his MD went up And then you look here, you can see the differentiation. And yet he had no progression on OCTs for 3 years. So Rob, do you think this is just an artifact, or is this a tailing out of the field loss that he may have had from the injured eye from the beginning? Because you do see that latter sort of late stage progression long after you get the pressure under control. In many patients, they'll keep getting worse while you have good pressure control and you're thinking you're failing, but it's really just the trails of the original trauma.
Mhm.
But in his case, I mean, he went up 2 units, which is almost 30%. And we did repeat that. It was very much the same. He was unaware of any difference in vision.
Yeah, I mean, this is the value of, all the progression software that now exists, like in OCT machines and now the visual field machines, to get kind of trend lines. But I would say it's worrisome, especially in a 33-year-old who have like that degree of visual field loss, no matter whether it was kind of residual from before. The other thing I always worry about with beta blockers in, the quote unquote normal tension glaucoma population is probably the best study looking at this, was by Ted Crouppen that compared brimonidine and timolol in the normal tension population had glaucoma. And, the results were that people on timolol got worse. The question was timolol making them worse, or was brimonidine protecting them, making them better? They both lowered IOP about the same, a little bit in this range. But the timolol group got significantly worse. So I worry about using a beta blocker in a patient, quote unquote normal pressure glaucomas. I think that's probably the one population it's good not to use a beta blocker in.
I absolutely agree. I actually don't use it at night anymore. I used to. I actually don't use it in the morning anymore. I've tried to move away from that. We're going to talk about that here in the next case. But he was an interesting case because eventually he did get through his MBA and he moved on, and he called me about 6 months later, and I got him connected to another clinician. And I do know that he underwent an SLT because he just wasn't compliant with medical therapy and had a lot of side effects from the topical therapy that they initiated. And I haven't touched base with him since, but he's an interesting example of that patient with a really complex nerve that's not in the mainstream of glaucoma. And you have to make a hard decision in the day-to-day clinics as to which way you want to go and for what, how you want to manage it. I agree with Rob. The best neuroprotection you can achieve is the lowest pressure you can get. So I think any of the drugs that can lower the pressure the most would be good. In particular, the ones we'll talk about in this case. So Rob, you can see the setup on this one. This is obviously a normal tension glaucoma patient, right? 40-year-old female on 2 meds already. Pressures are at 12. Notable asymmetry of the cup to disc ratio. The gonio was good. LBP history, longstanding history of low blood pressure. Bradycardia to a large degree. Rainouts with migraine. So she's sort of a trifecta patient. Here's the right eye. This is not a small nerve or a small cup. She's about a 0.65 to a 7 here. No field loss associated with this. OCTs were determined to be normal. But she's also a high myope. She's about a 5.5 to upper myope. Here's the left eye. And if you look closely at 5 o'clock, you'll see what looks like a little nugget. That's actually a optic pit that's developed since she developed the glaucoma. Rob, I'll have your comments on that. I'd love to hear what your thoughts are. I mean, optic pits are actually much more common than we think. The study by Stedman out of Baltimore, probably about a decade, maybe a little more ago, showed the incidence rate in glaucoma patients with normal tension was fairly high. In the open angle elevated pressure patients, they were there, but not nearly as common. But in either case, that pit is associated with a really large wedge defect, which you can't see. Well, you can see a little bit on the photo. And here's an old school OCT. This is time domain. But I think the piece that stands out here is if you look at the nerve in total, it's being read as being relatively normal, but that one sector at 5 o'clock has a 40, almost 40 unit thickness difference in that section, which matches the optic pit. And it looks just, there's another version of it. And it looks just like her field loss. So Rob, here we have a patient who's got normal tension disease. She's on 2 meds. Fields were repeated. They were a little equivocal. Then she showed up with a DRANS. Pressure was 14 and 15. What would you do next in a case like this? today, not back then. So she's on alpha-GAN, basically, and she's on a beta block, a selective beta blocker.
Yeah, I mean, so I think that's, appropriate medical therapy. I mean, there's still room to put her on a prostaglandin, I guess. But yeah, so you worry that this person is progressing at pressures in the mid-teens, assuming that, there's probably a little up and down, but they're somewhere in the teens. So you're getting progression. I mean, when I see a Drance hemorrhage, the question is, what's the meaning of a Drance hemorrhage or an optic nerve head hemorrhage? There's a lot of reasons people can get them, PVDs, diabetics. But when you have glaucoma, it's kind of I look at it as the glaucoma is progressing until proven otherwise. And sometimes you test them up and you kind of give it about 6 months for a visual field defect to show up. But, checking the OCTs, looking at structural tests, rechecking the visual field, you often will see it, 6 months later. But that said, when in doubt and this person already has significant visual field loss, you have to kind of assume that your control, whatever you're doing, is not enough. So, these days I'd probably, do cert. You could add another drop, but I think for someone this young, I'd want to have their pressure under 10 all the time, unfortunately.
So I elected at that time, go ahead and put her on latanoprost, and she dropped to 11, which is not unreasonable. Unfortunately, her systemic issues with the migraines really increased dramatically. She'd had a couple episodes of syncope due to low blood pressure. So we're dealing with a systemic disease that's manifesting as an ocular problem to a large degree. And the question then becomes, why does she have this? And I think in her case, it's probably none of these, but these all colleagues have to be ruled out. And I particularly am concerned about the previous history of steroid use. And Rob, you and I have shared a couple of patients where we've seen the patient. I saw that young lady that I sent to you with the pericranial injections with steroids. And when I saw her pressures had dropped considerably. Previously, she'd been up in the 40s, dropped down into the teens. And you look at the disc and she's wiped out and you think she's normal tension, but in fact, she's a burned out steroid glaucoma patient. Subacute angle closure has to be relieved or at least assessed. And quite frankly, there is so much more of that out there than you currently identify. And the hard part is gonioscopy is not done as routinely. But if you use your OCT and you use your angle assessment, you'll be really impressed. We're going to show you a case here in a couple of minutes where the angle is just beautifully rendered by the OCT and shows exactly what the disease state is. I mean, Rob, what's your number one differential on normal tension patients?
My sample is probably a little biased, but if they're phakic, assuming at this age they probably are. I mean, this is usually about the age when normal narrow angles start to show up or intermittent angle closure patients start to show up. I mean, this patient had already nodes. She already had kind of a vasculopathic, migraine history. So in some ways you could probably chalk it up to that, the underlying nerve weakness, but you certainly want to rule out, fluctuating eye pressure from intermittent, angle narrowing or closure. But this person's she's probably a vasculopath at this age.
So nocturnal hypotension is a real thing, colleagues. This is from Drance and Graham out of British Columbia at the BC Ophthalmology Center there, which I've been honored to lecture in on 4 occasions. Really amazing facility. They looked at 24-hour ambulatory BP, and there are patients who are nocturnal dippers. They'll drop their blood pressure 10 to 20% at night. And we know from Weinberg's work, which I'll show you in a minute, that eye pressure climbs at night. And so the damage is being done during sleep. They obviously have an increased risk of disc hemorrhage. This is Stimata and Colignin's work in the same space. About 10% of the population are big dippers, which is a large number. And there's an increased risk of MI. It is interesting that things like vein occlusion and other vascular AIONs tend to occur in the morning as the patient's awakening. That's when the disease hits, and it's because they've had this really remarkable imbalance between IOP and hypovolemic supply to the optic nerve. And this is Weinreb's work, and Rob, you can comment on this. You mentioned that Grubin did the same thing with his evaluation of timolol. I think this revolutionized the treatment of glaucoma. The fact that we know that the pressure goes up at night and timolol either does nothing or makes it worse. I look at a patient like this, and knowing what I know today, the first thing I'm going to do is refer him to my good colleague who's on this call with me tonight and say, let's do an SLT. I know we've had a lot of cases where we've done SLT on normal tension patients. I have my perspective on that. What are your thoughts on SLT in this case relative to normal tension individuals?
Well, I certainly think it's safe. The question is, any therapy in this pressure range, whatever was a PGA, you expect like 6 or 7 points when it's high pressure. This, if you get like 2 points, is clinically significant. Because when you look at the percent reductions, that becomes meaningful down in this range. So it's certainly a good thing to do. And when we talk about compliance, and there's data that shows that you get kind of a continuous alteration in the facility of outflow with SLT. So it's working for you once again, kind of around the clock. You decrease the fluctuation because, a lot of these patients, like I said, we're checking them for years at 9 a.m. in the office. And then one time you don't, and you see their pressure markedly different. So glaucoma patients, because of their compromised facility of outflow, fluctuate a lot more. And one pressure here and there, we just have to have a healthy index of suspicion that maybe we're not always capturing, especially when the people who are getting worse. If they're stable and you're capturing good numbers, okay. But it's these people who are getting worse, you have to step back a little bit. Yeah, they're fluctuating like crazy at nighttime or at the end of the day, or they, like I said, is their diastolic blood pressure bottoming out? They have to step back and look beyond just the usual office pressure readings.
And one of the reasons that I changed my perspective on this was, Rob very accurately reported that the average IOP lowering is probably 2 or less, in that high 1.5 to 2 range. And you might not think that's much, but as Ronnie looked at the patient on a 24-hour cycle and found that the diurnal variation was reduced significantly with SLT versus medication by itself. So I think SLT is a very appropriate treatment early on. And, in conjunction with medicine, this patient now still is at 11, but is holding ground over a long period of time. It has actually been very stable at about 11 or 12 at a third SLT done. The interesting piece is look at the bottom of that top bullet page there, 60 over 35 at night. We have a blood pressure system that allows us to measure systemic blood pressure every half hour for 24 hours. So she's really becoming almost hypovolemic in the evening, and we don't know what her IOP is or didn't have the opportunity to measure it. So these are really challenging patients, colleagues, and they are complex. There's a couple of things you can do. The one that I think is most important, because if it's that elderly patient, I see this all the time. The patient comes in, I said, how's your blood pressure? I'm looking at somebody whose pressure in the eye is 17 or 18, and they have notable damage and there's no meds on board. They haven't had any surgery at this point. And they'll say, oh, my blood pressure is great. My doctor tells me it's terrific. And then you need to separate out, is it low good? Is it normal good? Because a low blood pressure may look great to their general physician, but if they have progressive glaucoma, they just may be over-treating their general blood pressure disease. And I see this a lot in my elderly patients. Recent study from the American College of Cardiovascular Surgeons says that the average patient above the age of 70 should never have a blood pressure below 130 over about 80 under treatment, because it increases their risk of stroke and other vascular occlusive disease because it lowers the pressure at night. Rob, thoughts on treating these complex patients? Because this is not an easy treatment.
Yeah, I don't pretend that I'm a blood pressure expert. I usually send them back to the internist and just say, hey, this person has glaucoma. We're worried about, can you tell us about the diastolic blood pressure is what's important.
Exactly.
So can you do something, not to lower that so much? And especially, once again, going back, beta blockers, which work, they can have a beneficial effect on eye pressure for sure, but they're often the culprit. So you gotta be careful. And like I said, as you mentioned earlier, the timing of when you take them is really important. You don't want to be taking them at the end of the day. You want to have them early if you are.
So just a couple of comments about today's management of this case. There's been a shift from baseline. This is roclatan, which is a combination of latanoprost and Ropressa or Notardosil. This drug and the next drug I'm going to show you both have really remarkable impact on patients with relatively lower IOPs, right? So, or greater IOP reduction. So when I look at a patient like that today, this would be the drug that I would start. I would start this drug, which is Vyzulta, simply because they have such a increased potential to lower the patient to a much better level. This is the Jupiter study from the latanoprostene Blue Note FDA trials, or this is a study out of Japan actually. But Rob, I looked at this study when it first came out, and I thought that's really a remarkable IOP lowering for this low. You know, starting at 19 to get 5 consistently for a long period of time. So I've switched over to these two drugs as my first choice if they're commercially available, simply because they give me the best shot. I know you have a lot of patients you've treated with these agents. What are your thoughts?
Yeah, I think they work well, and I think they're systemically very safe, so we don't have to worry about, you know, that part of things. But I think, you know, when you look at the data, once again, the probability of success, I mean, they're as good as anything we can do in the office. That's for sure.
So Rob, I'm going to flip this over to you. If you want to do a quick review of MIGS, we've got about 10 or 15 minutes left. So why don't you start us off here, and we've got some really good cases on the other side of the aisle, on the surgical side. So
yeah, so the issue is now, you know, before 10 years ago, the issue is like, well, do we send the patient off to some nasty glaucoma surgery? You know, and then we basically started getting some less invasive surgeries. You know, ECP came out, trabectome, you know, the first kind of official MIGS was kind of iStents. But now the question is really not really, I think, less and less to do it, but like which one to do, because now we have a lot of different ways to kind of skin the cat here. We can put stents in, we can, you know, just dilate the canal. We can open up the canal by, you know, goniotomy or trabeculotomy. We have less invasive, you know, bypass procedures, subconjunctival filtering procedures, and we have more benign kind of laser procedures to decrease aqueous production. So it's amazing how much this field has changed and how many different options we have, just like we have in medications. It's amazing, all the choices, where it used to be, you know, trabeculectomy tube and prayer, I guess.
well, you know, one of my favorite conversations with a patient is when they develop a cataract and they have glaucoma, because now I've opened up the door to multiple additional options. And I'm going to tell you what I learned from my remarkably talented partner many years ago, how to have this conversation. Mm-hmm. When I start any glaucoma patient, my first comment is, and it's a paraphrase of Rob's work, so I'll just give him all the credit for this, but it works so well. I tell everybody, we're going to use a combination of medicine and surgery over your lifetime to control your pressure so you'll have good vision for the rest of your life. It's a simple statement. But in the most part, if you treat glaucoma long enough, it is an absolutely true statement. You will have to reach out to that surgical arm at some point if the patient lives long enough. This is the best opportunity. This is the apex when the cataract's ready and they have glaucoma, and now you have so many things you can do in the eye along with the cataract surgery, which also lowers pressure, to get a really solid reduction of IOP, which you may or may not have had going into the procedure. So Rob, I'll let you take this case away here. This one's yours.
Yeah, so I think, you know, this is as Jim said, I think that this is the best opportunity sometimes when patients has a cataract, and sometimes to say, you know, listen, your cataract's not horrible, but we're going to use this as an opportunity to lower your eye pressure. And I think people embrace that. I think, you know, medications have their place and they'll always have their place, but if we can minimize that, I think patients just have healthier, you can see it in their ocular surface is healthier. I think, you know, economically it's easier compliance, adherence, we always talk about. So it is an opportunity to, number one, make the patient see a little better, but also, you know, approach the glaucoma, because you can change especially in these narrow angle patients, taking the cataract out will help the angle configuration. And in the payment world, the one time you can put a stent in, i.e. what we have available in the US is the iStent or the Hydrus, these trabecular bypass devices, this is our opportunity when it's on label to do those, because that's how the study was done. So this is the one time we get to do that. And there's other procedures we can do on down the line. And even more, what we do these days is we combine it even more, where sometimes we'll do a canal-based procedure and do it with the trabecular bypass devices. So it's really an interesting time, and we're really working through, like, you know, optimizing therapeutic choices. But the nice thing is we do have so many choices. We just have to figure out, risk benefit of all of them. But this patient is pretty typical on one medication, fairly stable, not a home run success, but a decent response, knocking the pressure down from the upper 20s down to the low 20, about 20. Has some damage, so we don't, any pressure is lower. And I always tell the patients, if we can get you to the mid to low teens, that's the best case scenario. And a lot of times the data will show that cataract surgery alone might get you into the teens, but probably won't sustain it there for years and years. And that's the value of doing these MIGS procedures. It just increases our probability of success. So had moderate cataracts, we went ahead and treated at the time with an iStent. This is the original. This is one of the first studies. Is the original iStent we're going to use here. And this accomplished exactly best case scenario. And I never overpromised, but I said the best case scenario, we get you off meds and get your eye pressure down into the teens. So for one, mild to moderate glaucoma, mid to upper teens, where this patient landed. So this is the original iStent, and you put this in this. I always put it like it's a little periscope or a little snorkel. You place it into the canal of the Schlemm with this sideways motion. I usually do it after the cataract's out because I think the angle's a little more open. And then you basically place it, and then you have a little thing release. I'm just releasing it right now. As we're pausing here, once I kind of pull back and make sure it's seated in there well, and then that's it. So it's a very straightforward thing to do. When I talk about, additional risk to the patients, I always say you get a little bit of blood with these procedures more than you would with cataract surgery alone. Here you can see that stent placed with an endoscopic view, and this is perfect. You see a little bit of blood trickling there. And I always say the blood is a good thing. It means we hit the target. And but it usually, so there might be a little blurry after a combined procedure on the first day, but by week 1, it's almost always a wash. So I think in terms of risk benefit, it's a great advance. The iStent has kind of evolved. The studies have shown that putting multiple stents in is more likely to lower eye pressure better than a single one. So now we're in the second generation, which is this version of the iStent, where it's basically 2 little hollow rivets. So it's a little more straightforward insertion. But the nice thing is you have the opportunity to put multiple in. And these studies, once again, the studies have shown that 2 or 3 stents work better than 1, probably because you're getting closer to collector channels where, that's the money area. If you can really make the path to the collector channels as short as possible, that's where to go. Any comments?
You know what, Rob? I'm delighted that in that patient base where we're on one med and they're doing fairly well, that we're able to achieve success at the rate of about 75% of the patients are off medications for a prolonged period of time. Mm-hmm. I look at that procedure and say that's a 1 medication procedure for the most part, maybe 1.5. This takes it up a little bit because now you've increased the run because you're doing a cannular procedure along with the cataracts. Mm-hmm. I like this procedure. I know you like it a lot, and then we'll get to the next one, which I think is sort of the basis for a lot of the practice that we have in combining yet another procedure with the Omni, which I believe the Omni actually plays a major role in getting that pressure down and keeping it down, because you're completely changing the anatomic structure of the anterior chamber when you open up Schlemm's canal in totality. So go ahead and just walk through this one.
Yeah, so this case is a little farther along, so more moderate disease, a little bit more visual field damage and optic nerve head damage. This patient, started the angle from the cataract, was starting to get the angle was starting to narrow a bit. It's still open, but you always have in the back of your mind is, when in the dark, when this patient's dilated, is this angle more narrow than what I'm capturing here in the office? And it's dynamic. We didn't really go much depth into this, but the angle is dynamic in a phakic patient. You have to keep checking gonioscopy or evaluating the angle I'd say every year at least, just because it can change 1 year. I get caught sometimes myself. It's like, this angle this narrow last year when I saw this person, and a lot of times it's just changed from the growth of the cataract. The space is going away. So with this device, the Omni, argue it's probably the most kind of getting at the problem. It's basically, I always put it as like cleaning out your drains. So when I talk to the patient about it, so you basically inject this Prolene suture, hollow Prolene suture with viscoelastic, and in the canal of Schlemm. And it helps basically, and you'll see adhesions. this is a good case. This particular patient, this is, she had actually had eye stents placed before. You see them there, and they worked for a couple of years, but then they didn't. So here we're gonna do a vasodilation kind of around those and the other parts. And you can with this particular device, you can get 360 degrees. You do 181 direction, withdraw it, and then you can do 180 degrees back in the other direction. So, instead of just accessing what we can see surgically, which is always the simplest thing to do, this, because of the design, can dilate the whole thing. I think part of it's the mechanical suture going through, breaking adhesions, but also that stretching of trabecular meshwork has kind of long-standing value, and I think explains why it works over a period of time.
So Rob, let's do one more here. I think we have enough time to do this. We have about 4 or 5 minutes left. So
yeah,
this is a case that, by the way, that last one, I love that procedure for my patients because I know that I'm going to get at least one medication taken away. Sometimes maybe 2 medications, but I like the larger footprint that leaves as far as IOP control in conjunction with cataract.
mm-hmm.
But this is the procedure that I like the best, Omni with a Hydrus. And I'll let you talk about that one. This is a case where the pressures, obviously peak pressures were much higher. Patient's cataract's a little bit bigger, and we're looking to get pressures down considerably. So let me take you to this. There you go. Yeah.
So basically, when I do this procedure, the way I explain it, I think, these concepts, are borrowed a lot from cardiology, so I always say that, doing, the dilation of the canal is like, doing an angioplasty and then you leave a stent in. I mean, cardiology has been doing this forever. So why shouldn't we do it in glaucoma surgery? It makes a lot of sense. There's a lot of analogies there. And so, you basically dilate the canal, and then behind here, here's an example of the Hydrus, which is kind of a large device. It covers a few clock hours, but I think that's what delivers, good efficacy when it basically, because it does 2 things. It stretches the trabecular meshwork and through its windows, but also all that distance of 3 clock hours is kind of permanently dilated. So, sometimes the canal will recollapse, especially in more advanced disease. So after dilating it, the canal, we place the Hydrus in there and put the trabecular meshwork on stretch that way, which we already stretched with viscoelastic, but also it's remaining there to kind of keep it open for the longer term. So I think that explains why we can get, and there was always the big knock on MIGS. We couldn't reduce the pressure all that much. But I think with these newer procedures, especially combining them, we can have a great deal of success.
So this slide's an interesting summary of what we just talked about. So these are those pressures that you see on the base, 34, 25, and 22, are above what they achieved with cataract surgery. So as you can see, with the eye inject, a very successful procedure, another 22%. Mm-hmm. And, I had a discussion with a colleague of mine who's one of my best friends and is a real non-surgical, non-MIGS kind of person. He doesn't like MIGS, he likes trabeculectomies. He trained in the old school ways and, hasn't had a lot of experience in this space. And we were talking about this. He said, well, it's only 2 millimeters more. And I said, well, if you do the math, that 2 millimeters in a year is about 1 million units of IOP if you calculate every minute of that patient's life. Different, 1 million units different by getting that done. I look at that and say, that's a home run. And I think regardless of the expense, it puts the patient in a much better place. But the Hydrus against phaco is remarkable. But Rob, can you finish up our discussion tonight by talking a little bit about the Omni with Hydrus, which is obviously one of the procedures we do the most in the office?
Yeah, and as we said, we're basically, I believe in hedging bets. I have no shame in hedging bets. Once again, if you use multiple medications, you're never sure exactly which one is contributing the most. But I think that's true of our surgical procedures because we have these options. And I think, multiple points of attack, working on different parts of the system that in glaucoma, the angle, the trabecular meshwork, the canal schlemm, that's the diseased or suboptimal part of the system. So attacking it from a few different directions, much as we do with multiple drug therapy, I think is a good way to work. And I think it really works for us is, cleaning out the canal and then leaving the Hydrus in behind really has been, it's a game changer. It's kept people from a lot, more invasive surgery.
Well, colleagues, I believe we have reached our witching hour and certainly we're available for you at any point. We'll join you when the lectures are live and thanks so much.
All right. Thanks a lot.
Thank you so much for that wonderful lecture. And it has a special place in my heart because, you know, I can just tell that you two have been in the trenches together based on the lecture that you provided. You've worked together for a long time, the types of patients that you've seen. You both think so much alike, and it's so fun because, you know, I'm a little earlier in my career and I work alongside a glaucoma specialist, and a lot of the things that you were saying just resonated with me. So thanks for your time and your expertise with that particular lecture. Mm-hmm. Just want to get to a couple different questions that popped up. And, you know, one that came up was at the beginning in that first case, I believe there was the comments and a lot of questions in the chat box about what is a wiper defect. And Dr. Timmons, can you kind of explain that to the audience, what you're really looking at with a wiper defect?
Yeah, sure. So, you know, in the analysis of the glaucoma patient globally, RNFL was the original data point that we all became comfortable with, we use every day. But the ganglion cell analysis of the GCA has actually taken a very significant role, if not maybe the ascendant role, in the analysis of optic nerve changes. Some work by Don Hood originally demonstrated that the inferior hemisphere of the ganglion cells in the macular zone were more susceptible to damage. And as a result of that, that clean cut, almost like a nasal step in the visual field, is pathognomonic of the glaucoma patient. You'll frequently see that in a patient who you're on the borderline with. The RNFLs are questionable, not definitive, the visual fields aren't clear. And you see a wiper defect, and that would tell you almost immediately the patient is highly suspicious, if not glaucomatous. And more importantly, you need to shift that patient to a 10-2 visual field, because about 25% of those early wipers will show a field defect on 10-2 that they won't show on 24-2, which is a nice way to transition that patient through. I'm a big fan of the GCA. We use it for a lot of reasons in the office, and I think that's probably one of the more important ones. It's an early sign that may or may not show up on the RNFL, which is definitive, but helps a clinician move in the direction of going to treatment.
Now I'm going to ask a question to you, Dr. Noerker. You know, there was a comment that came up, or a question on the case with the optic nerve head dystrophy, and some comments about that. And the question came up, are there any tips that you would give the audience about distinguishing visual field loss secondary to glaucoma versus a visual field loss due to disc drusen?
Mm-hmm. So I think so. Yes, glaucoma visual field loss tends to be more predictable. That is, it typically starts with a nasal step in one of the hemispheres, and then might migrate over to an arcuate scotoma. So certainly, the action is nasally always in glaucoma. So optic nerve disc, defects, whether that you're trying to image structurally with OCT or on the visual field, tend to be much more random. So sometimes they might come close to, being a pure nasal step, but more often than not, they're a bit more random, like over on the temporal side or in a spot that may not correlate to where you expect to see changes in the optic nerve, and may not actually agree with OCT changes. Sometimes the correlation between OCT changes and visual field changes aren't as precise with drusen. So it's kind of the randomness, I think, makes you suspicious. When it just doesn't make sense, I think you're going to think more the defect is due to drusen. The trick is when patients have both glaucoma and drusen. That's when it gets really hard.
And then one final question. We got about a minute left. Dr. Timmons, how often in your clinical practice are you running a 24-2 versus a 10-2? And you alluded to it a little bit. And is there any technologies that maybe you can combine them with, or not?
A couple of sort of overviews for the audience, which I think is a very good question, by the way. 10-2s have sort of been put to the backside of practice, but I think they're incredibly valuable in three different circumstances. One, we're trying to define early loss when RNFL and 24-2 isn't present. We talked about that. Two, in patients who have plaquenil-based issues. So we do a lot of 10-2s. We just don't use them in the glaucoma space. But in the larger glaucoma context, anytime a patient has significant disease, moderate to greater than moderate, moderate to advanced, I think it's really obligated that you do a 10-2 alternating with a 24-2 on serial fields. And you should probably be doing those at least 3 times a year, maybe every 4 months, because that's the indicator. After, when the RNFL extinguishes and goes to the floor, which it happens to take place in that moderate to advanced stage, you really lose an opportunity to evaluate the patient. So the 10-2 is critical because, if I'm going to send a patient to Rob, I don't want to send them when they have 6 degrees of field left. I want to know what that 24-2 with the near fixation loss looks like and give him an opportunity to do something remarkable and bring the patient's, vision back to a longer term perspective.
Well, I can't thank you both enough for taking your time to be here with us, to share your expertise and to go through some cases. I thought it was excellent. Really enjoyed it. As I mentioned, it resonated so well with me. And I know with our audience as well, it resonated as the questions kept coming in. I couldn't even get to all of them. And so thank you so much. That is really a wrap on day 1 of Eyes on Glaucoma. I really want to thank everyone for attending. I don't know about you, but I had a blast. There was so much great information. And I'm already going to take a lot of this back to my clinic starting on Monday morning and implement a lot of these things. Just so as a reminder, please tomorrow visit the exhibit hall, visit the booths. There are raffle ticket codes out there right now. And our start time tomorrow is 7:45 Pacific time. And I plan on seeing many of you at that point in time. Thank you very much.
Thanks a lot.
Thanks so much. Enjoyed it. Appreciate it.